Yeah, Bismillah.
Perfect. Well, welcome everyone to our next webinar in our series of international workshops and webinars in medical education hosted by Imamia Medics International and Sadiq International Virtual University. I'd like to welcome you all to today's event on professionalism. And before I begin, we'll have the chair of the session speak, our facilitator, and then afterwards we'll have our next facilitator be introduced. Our first facilitator is Professor Dr. Gohar Wajid. He is a medical educationist appointed as a technical officer for the World Health Organization based in Cairo, Egypt. He's a visiting professor of medical education at the University of Lahore and Ripa International University, and he specializes in strategic and operational planning in health services. Welcome, and thank you so much for joining us today.
Thank you so much, Ms. Shifa, for this introduction. It's my honor and pleasure to coordinate and chair this session. Thank you so much, Sadiq International Virtual University, the whole team, especially Professor Shabi Zaidi, for particularly inviting me on to share my views on such an important topic, which is gaining more and more importance because of several factors, as we'll see in our discussions and presentations. Without wasting any time, let's proceed with the proceedings. So I would be inviting Professor Shabi Zaidi to have his presentation first, followed by brief questions and answers. Then there would be about 20 minutes presentation from me, and we will be open for discussion. So we'll try to keep as much time as possible for discussions. So it's my honor to invite Professor Shabi Zaidi, Vice Chancellor of Sadiq Virtual International University, a very dynamic personality. I did not know him, but for the past 1 year since this group was formed, that's where I got introduction to him, and I must say that I'm so much amazed by the particular motivation and the energy levels he creates in the group, and the way he has shown his dynamic personality is really impressive. So Professor Zaidi, all over to you, and we would be listening to your experience-based thoughts on this important issue of professionalism in medicine.
Thank you, Dr. Wajid. I'm grateful to you for your kind words. What we'll do is that I'll do a presentation through slides, which Shifa will kindly run for me from USA. And then after a few slides and discussions, like you said, for about 20 to 25 minutes, we'll have question and answers. Now, I'm only a humble student. I mean, you people are experienced and seasoned. Like I always say, I'm a lifetime learner, and I'm a student of ethics and medicine. It's been a wonderful journey, especially when we started the Sadiq International University, the physical form, which Dr. Bukhari is taking care of in Lahore, the virtual, which we started with the help of a conglomerate of speakers, scholars, academicians from all over the world. I am overwhelmed with the response. We started with only 5 or 6 people. Now we have about 210 or 215 regular customers, and then we have a lot of people who join in out of enthusiasm for learning. So like I've said in the past, that what has happened is that knowledge has come to your house. Instead of you going to the libraries or universities, knowledge has crossed all the barriers, transcended time and space, and come to your house, into your drawing rooms. And COVID, if there is any silver lining in this dark cloud, that could be only called in the form of e-learning, the process that we're going through right now. So I'll talk about professionalism and start with the basic definition and try to cover certain important, it's not possible to cover everything. Professionalism is like a book. It has 30 or 40 chapters. Each one could be converted into a webinar, but we'll try to introduce. So the learning objectives in today's webinar are, next slide, please. So we hope to at least introduce, not learn everything that's there, but the objective is that the salient components of professionalism, like patient patient-physician relationship, different models, rights and obligations. Rights must be balanced with obligations. Knowing one's competence and limitations. Next, please. Then we talk about care of the disabled, an extremely important factor and subject which regrettably is not given due importance in the developing countries, and I'd like to emphasize that during my discussion. Refusal of treatment is also an important subject. I'll briefly touch upon it. The conflict of interest, a very, very glaring phenomena which is happening at the moment right across the world. Privacy, which must be respected, confidentiality, anonymity, data. These are all technical words. They're basically legal terminologies which we have incorporated into medicine for professional reasons. I'll talk each one of them just touch upon it, and then we can expand later on. We have a whole lot of people who can expand each topic into a full seminar or a webinar over a period of time. Next, please. Also, I'll just briefly touch about truth-telling, breaking the bad news, self-referral, gifts from patients, financial arrangement between the patients directly or through the managed healthcare systems like insurance companies or third party. These are the objectives that I'd like to cover. There might be one or two more. Next slide, please. This is one subject which really fascinates me, and I'm very fond of it. And I have conducted one or two webinars in the past, but would like to do it again. A physician must be virtuous. Now, in the modern days, the best philosopher in medicine, philosophy in medicine combined together is Pellegrino. He recently passed away. That's his quote: a physician must be virtuous. But we've known it all along that virtue is an important attribute for a physician. And the cardinal rules were not given by Pellegrino, they were given by Plato as long for 3,000, 4,000 years back. And these are courage, compassion, phronesis, and justice. Now, when you have these elements, it leads to eudemonia. Eudemonia can only be defined as a state of total satisfaction, gratification, which I've described in my book as itminan qalb. The depth of your heart feels that you've done something useful. Then the other virtues that a physician should have are faith, loyalty, and trust. There are many more. There are about 12 different virtues which are important for a professional and a physician in particular to reach a state of eudaimonia, that is a sense of accomplishment. Next, please. Now, what exactly is professionalism? Professionalism has been defined in different forms, and this is a very standard modality or definition that I picked up from Google Scholar. Professionalism is a multifaceted attribute comprising of several components such as competence, trust, reliability, honesty, and ethics. And each one of them is a subject in its own right, which deserves one webinar on its own, but I'll try to cover some of these topics during the discussion. Next, please. The professionalism is a litmus test of rights and obligations. It expects a professional to have deep knowledge of the subject that he wants to call himself a professional or an expert, in-depth, rasikhuna fil ilm, problem-solving attitude. One of the objectives of a professional is to be able to solve the problem. To be a master of knowledge without practical skills or application of knowledge to solve the problems is like having a bow without an arrow. So you have a combination of knowledge with skills. Then leadership is important in a profession. Leadership for public, powerful speaking, convincing, talking to cohorts, peers, juniors, employees. In every organization, they give you a guidebook. And if you look at the guidebooks, for example, the NHS, everything is detailed, how to talk to your colleagues, to your juniors, to soon. That is all part of the professional attitude that you have to develop. Respect, not only respect to the others that you're giving, but also in the process, you gain respect for yourself. So over a period of time, if you're thorough in your professionalism, there is a Persian saying, which I can't remember, but something like this, Har ke wo khidmat karat, makhdoom shud. Forgive my Persian. Next, please. Anybody who serves is served in due course of time. Now, there are different values. I've covered secular mostly, but I'd just like to briefly mention about the Quranic dictates and Islamic perspective. And this is from my book that we are compiling at the moment on Islamic medical ethics. It's a compendium that professionalism from Islamic perspective should have 7 dimensions. Faith, that is Iman, piety or taqwa, best character, ahsan al-akhlaq, excellent performance, ittaqan al-amal, strive towards perfection, ijtihad, responsibility, amanat, and self-accountability, muhasabat al-nafs. That means all these factors, when you combine together, these attributes will give you the character of a professional, a thorough professional, to say the least. Next. One of the important things is in our religion, in our profession like medical profession, is to develop the relationship between a patient who is your, in modern terminology, the client. I hate that word, but I have to use it, unfortunately, because medicine, like from a higher altar of professionalism, has fallen to a level of trade. And that is the reason we're conducting this webinar, that we are not tradesmen. Great respect to traders, we respect them, but profession is a profession. And in order to build a relationship with your patient, there are certain models which have been defined and developed by experts. The first and foremost is the paternalistic model, which has been customary. We're all familiar with it. Over the period of time, those of us who have practiced for years, we know that a patient, there was a time when the patient would come and say, "The doctor, you don't have to tell me, you know the best." Now, that was a good practice for a long, long period of time because knowledge was limited and skills were not really required. But when knowledge expanded because of all the technology and advancement and everything, physicians did not know it all. Therefore, the paternalistic model faded into different models. Next, please. The second model is an informative model where information is shared and a contract is drawn between both stakeholders. So you discuss the various aspects without being a party to it. You just discuss and talk about it. You give the information about the procedure. Next, please. Third model is the consultative model where a physician provides all the relevant information, including the need or desire of conducting certain tests. An informed decision is made by the patient. Doctor is not a party to decision making. He only gives an advice and gives the information. Next, please. This is my favorite, deliberative model, where you are like a friend, not sitting at a high altar as a professional, but come down to the level of a patient, talk to each other as a family member, discuss the good and bad points, lead the pathway towards each other, and then you reach a certain result. Objective, of course, is welfare. Next, please. Rights and obligations must be matched. Physicians have a right to exercise their professional authority and are obliged to provide maximum relief to the patient. A patient has a right to expect the best possible care, and both parties can withdraw from the arrangement at a convenient time. That I'll talk briefly in a minute. Next, please. Care of the disabled is an important subject, which is of extreme value and has been duly recognized globally. But in the West, we have special facilities for transportation, for mobility, for Blue Badge. HCA is available, convenience of movement, chaperone, everything. Unfortunately, in the developing countries, we're still far behind, and we have to emphasize the importance of care of the disabled. Mental health issues rising continuously, particularly the COVID era, due to solitude and all. Hugely important, and I hope to conduct a webinar with Annie Shamsi in due course of time on this particular subject. Next, please. Pillars of medical ethics are autonomy, beneficence, non-maleficence, and justice. This is a very standard book, Bucham and Children's, that was published in 1992. These are standard models. Next, please. I'll have to rush through because I have a few more slides. Informed consent is the spine of autonomy. Autonomy is the fundamental pillar of ethics. Informed consent is the process in which a healthcare provider educates a patient about the risks and benefits, alternative therapies, and whatever procedure has to be given. The patient must be competent, and that's important, must be competent to make a voluntary decision about whether or not to go ahead. There is a special column of those factors, people who cannot decide for themselves, so like someone who's mentally disabled or a child or a minor. And I will one day conduct a webinar with Dr. Iftikhar of King's College for consent in children. Next, please. Different forms of consent. That's the credit I'd like to give to my late colleague, Maqbool Jafri, who gave me this information many years ago. The different forms which are given here: implied consent, express consent, specific consent, deferred consent, general consent. The commonest variety is implied. You go to a doctor, ask for an injection. You don't have to say the doctor, right? The nurse will tell you, I'm going to give you an injection. You just give a nod and that's it. Next, please. Surrogate consent is very popular in the developing countries, where a tribal chief, a head or chaudhry or malik gives the consent, particularly in collaborative programs, to his wards and for all. Now, that is an important subject to remember, because a lot of people go from here to different countries in the Eastern nations, and the chief he's genuine and right and honest and fair and takes care of the word. Sometimes he might be a greedy fellow, so you have to be careful about this consent, where surrogate consent is adopted in research. And most of these subjects are uninformed. Next, please. Confidentiality is a very important subject in modern medical care. It means not sharing the personal data with other professionals, such as an attorney or a physical therapist or any other person, without the explicit consent of the person concerned. Next, please. Privacy is different to confidentiality. Privacy is defined as an individual's right to be free from intrusion or interference by others, and it has different categories. Next, please. Privacy is either physical, it concerns about access to your person, or personal space. Even within a house, everybody, husband and wife, brother, sister, family, father, everybody needs a personal space. That is privacy. Information privacy concerns about the access to personal information, details about individual character, or habits, or whatever. Next, please. Then you have proprietary privacy, concerns about the appropriation and ownership of interest in human personality. Everybody has a personality, so you're not allowed to share it without explicit consent. Then decisional privacy, concerns about the government and other third-party interference with personal choices. Next, please. Common law and morality are very important things. Confidentiality is an ethical duty. Privacy is a right rooted in common law. That is the difference between the two things. Next, please. Privacy applies to a person, like we say that, leave me alone. I want to be alone in my personal space. Confidentiality pertains to data, identified data like nature of illness, prognosis, etc. Next, please. You can refuse, the doctor can refuse to treat a patient. The patient can also refuse to undergo treatment, like after a chemoradiation or reaction of financial consent, or sometimes sheer ignorance. And that is where the importance of professional comes in, that if it's due to sheer ignorance, the doctor's duty is not to just give up, try to explain even further, because tragedies do happen in certain countries, and I know one or two experiences myself. Next, please. Conflict of interest is an old dictum from Indian subcontinent, khai kisi ki, gai kisi ki. It's a very common thing. That means you work for the state and you you use your expertise and your position and refer your patients from the state hospital to a private practice, making very common, or your course, your students or juniors to send the patient to a private practice. This is the other one, prescription of a certain drug or a device which may not have been approved, but because you have been bribed or you've been given certain benefits, then you use it. Very common practice. Conflict of interest must be avoided. Next, please. Now, collaborative research is very common. I mean, I was in Pakistan most of my life. People will come for research. Many times these collaborations are genuine and honest, but sometimes doctors or nurses or colleagues are bribed, and that amount of money which goes in traveling, excursion, or whatever, is then transferred as a burden or liability to the cost of the drug. That is called sick tax. It must be condemned. Next, please. I'll go through the slides quickly. Coming to the last bit. Anti-vaccine drive. COVID has created a huge problem. This nanoparticle has destroyed the mankind. And the moment the vaccines have begun to come, people have started campaigning it. There are some vested interests. I mean, maybe ignorance. People in Pakistan, for example, Dr. Bukhari was just telling us a moment ago, people still do not realize the impact of COVID virus. They still feel that is probably just hearsay or a afwah, which is not true. Anti-vaccine drive is already in full swing. I'm surprised, very capable people in sports, for example, they're coming forward. Now, it happened some time ago on measles also. And how should a health professional behave? That's the question. And I feel that we have to fight for vaccine therapy. Anti-vaccine therapy, anti-vaccine drive must be condemned. Next, please. Then this is a denial of reality. In Pakistan, polio is a Dr. Wajid from WHO knows more than I do. Denial that there is nothing like polio. There's nothing like viral, COVID, denial that leads to a big problem. It's only 2 countries, Pakistan and Afghanistan, I think Nigeria also, where polio still persists because the religious authorities and ignorant people are against it. That needs to be condemned. In Western countries, we had this problem some years ago when autism was connected with measles vaccine. That was then eventually a lot of research was carried out and was refuted. That's not true. Next, please. This is a new thing that's come in the last few years, and Dr. Fahim Nanjiani will join us to tell us more about it. WHO defines it as a healing from a distance. Medical technology enables a physician to reach out to a patient remotely. Very, very popular these days, telemedicine. Next. Telehealth is where you're teaching, like this is telehealth that we're doing right now, managerial matters, CME, educational activities, training of the health professionals. Now, this is very common, and I'll ask Fahim to come and talk to us about it. COVID-19 has given it's a perfect example of using telehealth for teaching and reaching out to many countries and people across the world. Next, please. Financial relationship, as long as within certain norms, it's accepted. Of course, we work for ourselves, so we charge a fee. But that professional fee should be compatible with the service that you're giving, also affordability. It's a major problem in many developing countries. Also here, a lot of factors which I cannot discuss because of short of time. Next, please. This is a problem in many, especially USA, and not in Canada, USA. Managed healthcare insurance are not starting in Pakistan also. When you have third parties who get involved, like insurance companies, a lot of information that is to be shared has to be carefully shared because it can be used against it. The cost of insurance can go up. Next, please. Very important factor, truth must be told. It's a moral obligation. Like, for example, talking about a disease, its prognosis, because the patient has to write a will, take care of the family matters. So truth must be told. Fear of taking away a patient's hope is a common reason. I emphasize a common reason why sometimes healthcare professionals may not tell the truth. Next, please. So you withhold truth. Truth must be told. However, sometimes beneficence and non-beneficence supersede autonomy. Normally, when the patient comes, we have to tell the patient the truth about the sickness. But in certain, particularly in the Eastern cultures, when we have family bondages, a family member will come forward and say that, please, doctor, don't give the bad news to my uncle or father or whatever. Can you tell me first, and then I'll share. This is autonomy giving second position to benefit. In the benefit, towards the benefit of the patient, you withhold truth. Withholding truth is not the same as telling a lie. That's an important factor. Next, please. Then it's a very common practice to refer the patient from your government hospital to your private practice, or you coerce your juniors or colleagues. Very common practice. There must be, I've seen the NHS, private patients from the NHS are referred to private practice. It is to be condemned. Next, please. We're almost there. Almost there. Next, please. I'm sorry, I have to run too quickly. Gifts from the patient. Sometimes the patient feels that here you've done extra favor. He brings a gift to you. Is it ethically right to accept such a gift? Yes, it is right if it's within a certain norm. But if it's an extraordinary gift, etc., then that must be declared. You cannot accept it. Next, please. Medical errors, very common. We have to be extremely careful. We're all human beings. We all commit mistakes. The moment a mistake is committed, a medical error is carried out, or you have committed a fault in your clinical care or diagnostic or therapy, you must be very careful to document it as a professional. Dr. Hassan Zaidi is listening. He is a very seasoned NHS consultant. He'll tell us more later on. It must be documented. What happened, why happened, what could be the harmful effect. It must be documented because you want to learn lessons from it. Also, and this is the sad part of it, that in Europe and USA, we have medical protection societies and defense. In Iraq, for example, I know there is no such. So the doctor has to face the wrath of the family. Big, big problem. And we can discuss it during the discussion when we go forward. Next, please. Breaking bad news is a very, very difficult subject, very common. All of us have to do it once in a while. So you have to choose the right time, choose a proper corner where you sit quietly and talk to the patient's relative next of kin with great expertise. You need special news, and we can conduct a full webinar on communication skills in due course of time. Next, please. So how do you handle it? A gentle touch on the shoulder of next of kin, and eye contact, and appropriate body gesture, and empathy, not sympathy. Empathy, not sympathy is important. Next, please. And towards the end, I think. Last 3 slides. This is a new thing that's come up. Dr. Sholay kindly allowed me to use some of these slides from Google Scholar. E-professionalism is the way to engage online. This is what we're doing at the moment. And you have to adhere to certain professional codes of conduct. Next, please. Social media, everybody's familiar with it. There are certain important things that you have to be careful, especially that we've had in the recent past with the problem with social media, fake news, and what have you. Next, please. Every time you use e-learning methods or you use e-technology, you leave certain digital footprints. Professionalism means that you must keep in mind the principles of honesty, integrity, reliability, responsibility, and respect. Your footprint is left everywhere. It can be traced. You have to be careful what you're doing online. Be careful with your words and with your written material. Next, please. This is common these days, electronic medical register and recording. There is a problem that can happen. This can be spilled over and happened in NHS a few years ago when we had to stop all the work on the computers the moment it was hacked. And then we had to go back to old-fashioned paper and pencil and things. So we have to be careful. Next, please. The word that's used for etiquette of this new technology is netiquette. Code of conduct in the use of internet, extremely important in the present era of tech. This is the word technagogy that I picked up from Hasnan Baluch in one of the discussions. Technagogy means that you have to be more careful in the present area, and that etiquette is called netiquette. Next, please. Data protection is extremely important. It's very vulnerable during the electronic EMR and online courses, but otherwise also in the UK, they've started this GDPR from 2018. Data cannot be shared without a proper process. You have to follow a certain process. USB sticks, for example, non-encrypted computers, it should not be used. One has to be very careful. Internet availability is a major issue in a lot of countries. A lot of our friends from Iraq, for example, or from Somalia or from Nigeria cannot join these webinars because of internet. Next, please. And these are the references. One more. Next, final. Thank you. They will all go onto the web page of. And I'm at your service to answer any questions. Thank you. I overtook by 5 to 7 minutes. Do apologize. Thank you.
Thank you so much.
Thank you so much, Professor Zaidi, for a very... Yes, go ahead, Dr. Shifa.
No, thank you so much.
Answers?
Yes, what I'll do is before we go on, I'll ask Dr. Tabassum Zahra to please join us for posing some of those questions. They started to come in the Q&A chat and the chat box. So perhaps she'll be able to post some of these and we can have both of you weigh in.
Thank you, Shifa. Yeah, we have some questions who have come in for Dr. Shabi Zaidi. The first question is related to the word that is being used, either a patient or a client. The question is, which is a neutral word? In some of the disciplines, it's not right to call patient for a person who is coming in for a physiological process, like in obstetrics and gynecology. When a patient is coming in, particularly a woman who is pregnant and is coming in for her local or routine checkup. So the question is, what is the right word?
Right. Now, patient for me is always a patient, and a subject is not a patient. Subject who comes, for example, for research, for discussion, etc., who's not really a patient is a subject. A lot of times when you do clinical trials, you have healthy people, so they're called subjects. Patient is a patient who has a disease, who comes with a disease. This new word called client has come up in the last few years because of the change in the radical, or not just change, radical change in medical practices. Unfortunately, that is the reason I believe professionalism has to be taken back to the high altar that it used to be. You see, as long as patient was a patient, we were called doctors. Now, even in my clinic, I remember one particular example in, I think it was last year in north of London, in an NHS clinic. A woman brought a child, and the child has a problem with the ear, etc. So instead of saying that, doctor, can you see my, she would say, she told her son, Peter, go sit on the chair, show the ear to the man, show the ear to man, not doctor, not physician, not sir, nothing. So the entire etiquette is gone. And that is a sad story which is happening. I would still call patient, but because of the legal reasons, these days we have to use the word client for the patient and health worker for a doctor or a nurse. Now, health worker does not mean only doctor. It means healthcare worker, healthcare assistant, professor of medicine or surgery, or just an ordinary nurse, or not ordinary, but nurse. So it's a broad terminology. But patient is patient and a subject is subject. Healthy person is a subject, patient is one who comes with disease. Thank you.
Thank you, Dr. Zedi. There is another question which is related to medical ethics, and it talks about asking how to train effectively the students, consultants regarding breaking bad news at the start of life and towards the end of life. For example, if there is a bad news to be given to a parent about the child which is born with some congenital problem, and if you are to break a bad news towards the end of life. So how we are going to train our students, our learners in this respect?
Well, the best answer is that you have to join a club or a group or do an exercise like a workshop with social psychologists. I remember in Dow, I used to do these workshops many, many years ago, and I'd invite a social psychologist or a social worker. They are the best people. But like I said, empathy is important, not sympathy. That means you share the burden of that loss. You get involved as if it's happened to your own family. Not sympathize, because sympathy means that you're coming from a higher altar, which is not advisable. Like I said, you have to find a proper time, a proper corner, quiet, sedate atmosphere where you can share it gradually and peacefully. Breaking bad news is a very difficult subject and can react. So you have to go through a learning process. But very basic thing is find a proper time, time convenient to the next of kin, convenient to the patient family or patient himself, not to do. Find a quiet corner, develop an understanding, an eye contact, body gesture, gentle touch on the shoulder, and then gradually break the bad news. Of course, not giving false hopes. Be factual. Technical jargon must be avoided. It should be factual and to the point. Thank you.
Okay. The next question is related to the boundaries of professionalism. As we all know that professionalism is a very vast term, and the boundaries cannot be curtailed. But how is it possible to curtail this issue of professionalism within boundaries?
Like I said, the fundamental pillars, you might call, of professionalism is 4 or 5. Competence, respect, dignity, honor, values like virtues. I mentioned about compassion, truth-telling, honesty, and faith. If you have these various things, this will be more like a concoction of various things, but each attribute has its own character. And like I mentioned about the name of Pellegrino, if you read Pellegrino, it's available on the literature internet. Edmund Pellegrino has written extensively. He's brought philosophy into medicine, like it used to be in olden times, then it disappeared. Philosophy must be taught, and I've been saying it for years. Instead of teaching zoology and botany, no disrespect to them, instead of teaching zoology and botany, we should be teaching philosophy and social sciences, because we're dealing with human beings. So if you understand how to empathize, how to respect the other person, how to give equal status, then you obviously, so the compartments of professionalism are boundless. There is no limit. Each one of them can be expanded. But suffice to say at this moment that if you have just those values that Plato described, that Pellegrino has described, courage, compassion, phronesis. Phronesis means practical wisdom. And then justice. Justice, in my view, is the fundamental brick. Justice is the pillar. If you observe justice in your practical life, then you cannot go wrong. And justice is something which should be seen. And justice is also a representative of your conscience. So what happens, what your conscience appeals is what is justice. So you feel about a certain thing and apply in a practical form, that is justice. Thank you.
So the last question which is coming in is related to the symbolic frame that we talk about, the white coat of the doctors.
Yes.
The question is that nowadays this has been discouraged and it's becoming obsolete, that the doctors are not wearing, the white coat. So what are your views on that?
Oh, wonderful. It's a beautiful question. Exactly what I've written in my book as a full 2 or 3 paragraphs on it. You see, the thing is, there was a time when we were trained, like, the white coat ceremony used to be a standard modality. Even today, I mean, I remember in Barbados when we did it, of course, in American University of Barbados, we had a specialist. In the UK, what has happened is that because of certain political reasons, somehow the doctors are condemned. And because, it's a long story, I can't say on the net, etc. But you can read it up. There's story in the literature. They had a special status. They said, look, why should a doctor have a special status? Well, take off the bloody coat. We don't need a white coat. Get it off. Okay, fine. Then say, roll up the sleeves because you're spreading infection. Take out your tie because spreading infection. What about other things that you carry all around? In the theater, for example, what has changed is the mask is gone. We just wear the caps. No mask. Then you wear the slippers in the theater, you go to the corridor with the same. Everything is changed. And I fail to understand why. But obviously there are reasons beyond my comprehension. What I would say is that dignity must be maintained. To have a white collar, a decent shirt, decent. One of the important things of professionalism is appearance. You should be properly attired. You should be properly attired. White coat gives you a dignity. Stethoscope may have gone, but as a symbol, if you have stethoscope in your hand, you're respected. And I'm a strong believer that wherever you can maintain that, please maintain it.
So, Dr. Zedi, there's one more question which is pertinent and I think should be answered. How could we teach professionalism? I think you have already answered that, but if you can just summarize and give a brief answer to this important aspect.
Right. You can have professionalism as a part of your curriculum, but more importantly, as a hidden curriculum. So role modeling is an important example, is a very good model. So if you have a class, a batch of students, and you're the teacher, you develop those habits, those traits to be a professional. Because the whole process is a process of transmission of knowledge and technology through a process of osmosis, the student follows you. There is always a role model. I remember we had a role model in the form of Professor Fazl Elahi and Naeem Jaffrey. Even today, I think that they were the best teachers. They were the best people, proper, respectable, decently attired, not rich by any means, but so all those factors. So role modeling. Then you can also inculcate professionalism by practicing in your clinics. Show them courtesy and dignity and honor and respect and values, and talk about truth telling, all those things through actual curriculum as a part of curriculum, but also as hidden curriculum. Thank you.
I think there are no more relevant
That's
and
it.
important
Thank
questions.
you. So most grateful to you.
You're welcome. Over to Dr. Gohar, please.
Shifa, maybe.
Yes, next we'll have Dr. Gohar speak. If I can get you to please unmute and begin.
Thank you so much, Ms. Shifa. And let me share my screen straight away. And thank you so much, Professor Zedi. It was a very comprehensive overview of different attributes of professionalism. And thank you for differentiating between some of the fundamental pillars. And then you mentioned about 30 to 40 different attributes. I guess there are another 40, 50 attributes that can still be included in the whole buffet of that falls under professionalism. You have made my job easy, and then I would be taking this subject one step ahead and discuss three important aspects that relate to the semantics of professionalism, what you have already mentioned. So very briefly, I would be talking about what should be taught under professionalism, then how much should be taught, how are we going to teach it, as one of the participants already asked, and then how are we going to assess it. So my talk would be more relating to the educational aspects of professionalism, how to operationalize it from its constitutional definition to getting into the operational definition and getting professionalism into practice. And I'm thankful to my colleagues and my students who responded to the 11th hour. I did not have a presentation just 3 days ago. I had to ask my colleagues, can you share your presentations with me? So probably there is nothing that is from me in this presentation. Most of the slides I have taken from all these colleagues whose names are appearing in front of you, starting from Dr. Raki Usman, Ahsan Brekhna, Saima, and Noore Kiran. So why professionalism has gained so much importance over the years, Professor Zadi has already discussed briefly. But we can see that there is a whole lot of literature now available, and our quick review of literature shows that around 80% of the literature on professionalism has evolved over the past 2 decades. So that's how important different dimensions of this multifaceted subject has come up with. And why it is gaining so much importance, there are a whole lot of issues starting from the complexity of evolving dynamism and complexity around patient and doctor relationship that we are seeing today, where multiple stakeholders are involved, and there is I call it the knowledge about patient rights and the contractual obligations between the doctors and patients, etc. I won't get into the details because of the shortage of time. Then we have seen that there is increasingly vocal patients for many reasons, and one of the reasons we have seen increasing amount of information, whether right or wrong, that is available on the internet, and the issues that relate to, again, with patient rights. Now, what would it lead to if we omit professionalism? Then what we would be left with is what we call unprofessional behavior. And if we let this unprofessional behavior among all health professionals go unchecked, then ultimately the medical profession is going to lose its autonomy. That would be something sad to happen if it happens. So through those self-regulatory mechanisms, the medical professionals have to come up with the strategies on how best they can very structurally incorporate professionalism within their curricula, so that we make sure that a doctor or any health professional for that matter, once he passes out through the institution like medical college, he exhibits those professional attitude and behavior that is expected of the professional. There is increasing emphasis on the social contract, as we have seen in terms of the changes happening in NHS and several other countries, and the obligation then it falls on medical professionals as well to exhibit all those professional attributes and qualities that are expected of them as a part of social contract. We have seen over the past maybe 2-3 decades increasing emphasis on medical errors and omissions, or whatever you call them, that has led to increasing lawsuits and malpractices and patient complaints. that has led to the more defining and redefining of professional boundaries of all health professionals, including doctors. Then medicine over the years, we have seen that it has gone much complex, and through the involvement of multiple stakeholders, as we are seeing, including pharmaceutical companies, and some of the aspects were very nicely covered by Professor Zedi. And then the government appearing as a very important stakeholders in terms of curtailing the finances, because we cannot go the financial aspects of medicine just unchecked. As we have seen, the financial burden and the cost borne by the society is tremendous in terms of providing healthcare services. So what is expected from a health professional, from a doctor as a professional? Three broad categories, I would say. One is while the doctor is dealing with the patients, then when the doctor is dealing with the colleagues, and we can then attribute it to the whole society when the doctor is dealing with the society, doctor as community leader, what we call the attribute, the specific attribute of the doctor, because naturally any society, it gives certain status to the doctor. Society views doctor at certain level, so that level, that status demands that there has to be certain professional attributes among the doctors that address that specific social contract that is there between the doctor and the society. So my presentation would briefly be touching upon the curriculum aspects of this relationship, and how to teach, and then how to assess professionalism in these three domains. There are several, we have seen that there are so many aspects of curriculum that are covered in different curricula, and they vary from society and from culture to culture, because professionalism itself is a multidimensional attribute. Then we see, as a result, there are so many models of medical professionalism emerging, so many ways of teaching and learning emerging, as Professor Zadi mentioned, of role modeling, etc. And then assessment issues related to medical professionalism. As I have said, that professionalism is a multifaceted issue. So in order to determine what exactly goes in the curriculum, we need to understand the very essence and nature of professionalism that might even vary from society to society. So we need to keep in mind the national consensus development on what goes exactly in professionalism. There are over 100 medical colleges in Pakistan alone. So we cannot have 100 definitions of professionalism and 100 different kinds of models being followed by these. Some kind of outcome oriented approach has to be there, where somebody has to establish the very core definition of professionalism that needs to be followed by the medical institutions. Then attributes of professionalism and teaching and learning and assessment strategies. I won't get into the details of all these attributes. They have been covered very nicely by Professor Zedi. What I would emphasize is that professionalism has to be taken as core competency and addressed as core competency and in each curricula. Since it is contextual and it could vary from culture to culture, and the roles could vary, so the core of professionalism has to be very well defined by any institution or a regulatory body. And then we can make the job easy by defining, once the outcomes and the competencies are defined, we can define what is the cognitive component of that professionalism, what we need to teach, which means what goes as knowledge. Then what are the psychomotor skills that we need to impart in doctors in order to address professionalism issues? Psychomotor skills, for example, communication skills. One might address breaking bad news under the domain of professionalism, rather maybe under communication skills, or the whole issue of communication skills, the competency of communication skills can be embedded within professionalism. And then last but not the least, the Bloom taxonomy affective domain on how to change the behavior and what kind of behavior and attitude is expected of a health professional, in this case, a doctor. So that could be one very quick way of breaking down competencies into the Bloom taxonomy domains and addressing them in the curricula. I will quickly touch upon different models. There are so many different models available that have emerged as a result of the definitions and the attributes of professionalism. For example, there is multidimensional model by Hodges presented, which includes and sees the professionalism at the individual level, as discussed again by Professor Zadi, in terms of altruism, empathy, honesty, confidentiality, privacy, and all these issues. Then professionalism at institutional level, then interpersonal level, and societal and cultural level. And the other models that I'm going to show you will also follow the same pattern, and they have been developed on addressing the same theoretical models of individuals, interpersonal, institutional, and societal roles. So again, this model is again multidimensional. Reflective practitioner model, then reflection as a core of professionalism, which is unfortunately not addressed in most of our curricula. And then communication skills, briefly I touched upon that it has to be there as one of the core subjects to teach. Now, if we talk of certain ethical principles that are going to help you to inform professionalism, like the fundamental pillars of professionalism in terms of maybe dignity and justice and fairness and empathy and ethics, then all these feed into the model of professionalism, that is reflective practice model. Then approaches based on, again, from patient-centered to personal-centered, family-centered, and community-centered or societal-centered approaches. This is again one model of that was used in describing professionalism. There could be several spiritual and religious models as well that are that could be based on self-exploration theories. I will touch upon one of the models that revolves around the beliefs, values, attitudes, and behaviors. Don't have the detail to discuss them at level. Then theme-based models, again with around these attributes and behaviors: human values, ethical principles, communication skills, belief, and cultural domains. If you put them all together, you could come up with one model around professionalism that could be used in teaching professionalism to our students. Then there are so many outcome-based and role-based models as well around the different roles of the doctor. As doctor, I said one of the roles is doctor as community leader, doctor as administrator within the institute, or scholar, or researcher, or teacher, etc. Now, let me explain you the process-based model that was developed by one of my colleagues, Dr. Usman Mehboob, which as a part of his PhD, which revolves around seeing professionalism as fruits on the tree. He uses this analogy of apple tree, where he says that the society what sees or what expect to see in a doctor are the outcomes or the fruits on the tree, and these are the outcomes that can be defined and included in any curricula by any institution in terms of trust, care, empathy, etc. And you can change, by the way, the fruits. These are not just hard and fast rules that they must be there. There could be many other fruits as well. So that's how the society expects that a medical professional will appear. Now, in order to achieve that, self-regulation, Usman presents that self-regulation is the way where these fruits can be achieved. And this self-regulation then is based on the roots which are usually not seen by the society, but these are the ones that actually any health professional faces on daily basis in terms of his roles in the society, roles in the institution, the kind of uncertainties he faces, the kind of power struggles going on within the society, within the institution and the society, and the professional dilemmas we face. All these the hidden aspects that form the conflicts and the hidden part of any curriculum that needs to be taken care of by the health professionals. So through self-regulation, he proposes that the outcome-oriented fruits that can be elaborated, that can be defined by the societies in order to address. Then I would specifically like to mention the four gates model that included actually dealing with God as the fourth gate. That was one of my PhD students from Maastricht, Dr. Iraqi, who presented this model as part of his thesis while defining professionalism in the Arabian context. And again, you can see that he started with dealing with self, then dealing with the task, dealing with others, and dealing with God. And when we reach to dealing with God, the level, and then if you see the two attributes, number 7 and 8, what he describes is self-accountability in terms of what Dr. Zedi called taqwa, and then leading to self-motivation, what he calls here the expected reward from the God. That is, again, that we expect certain rewards from God only. These are not expected even from the society. So starting from self-awareness and management and going through the pathway of excellence, then we are accountable, and we say that we are accountable first, maybe later on to the society, but all of us are accountable, being Muslims, to God. So that's the Muslim perspective, of Arabian perspective of professionalism. I won't touch upon this model by Bandura. That is professional identity formation model that was discussed in detail by one of my colleagues, his PhD in medical education, specifically addressing the issue of how to form professional identity of doctors. So when do we start feeling and saying that now I carry the identity of a doctor and I must abide by the rules and regulations and roles and responsibilities that are vested upon me by the society, being a professional doctor? So that professional identity formation is very important. That has been explained by many researchers in the form of different theoretical models. So touching upon these models, let me spend few minutes with assessment issues. When we have taught through role modeling or through distributing it Bloom's taxonomy on what goes about knowledge, what goes about psychomotor skills, and what goes about the attitude and behavior of related to professionalism, then comes how are we going to assess it? Again, assessment of professionalism is a pretty complicated issue because it's further divided into, you have seen, in so many domains. And these are some of the ways that there are so many tools basically available to assess professionalism. But we need to keep in mind the difficulties that revolve around the reflectiveness, the advocacy, that the nature of lifelong learning, and the uncertainties that are there within the domain of professionalism. So while we keep in mind there are so many tools available, we all know about those knowledge-based tools, psychomotor domain, and like workplace-based assessment, etc. So we need to very rightly pick and choose the tools that will create that assessment model that is going to be most valid and reliable and practicable and feasible model of assessment. And this model could vary again from institution to institution. Like, for example, Cruz and Cruz suggests that there could be some written tests, an oral exam, and OSCEs, direct observation, workplace-based assessment tools. I'm very fond of personally portfolios and 360-degree evaluation, etc. that can go in any assessment model to measure the knowledge and behavior of doctors. Then let me, in order to save time, let me present that it has to be divided between a very fine balance of what goes in formative assessment and what goes precisely in summative assessment, high stake assessment at the end, and how an institution is going to build that model through which assessment as an outcome oriented distinct structured entity can be measured. So I would be ending it here. This had given me the idea that we can have, in fact, a whole day workshop or conference on medical professionalism, addressing the issues like semantics of medical professionalism. It was briefly touched by Professor Zeddy. Then social cultural aspects of professionalism, how to introduce professionalism in a curriculum, how to teach and learn about professionalism, and then how to assess professionalism. So we can have a whole international conference around these issues. And I thank you very much for your kind attention. And with this, I would end my presentation. Thank you so much.
Thank you so much, Dr. Gohar. I will ask the audience if they have any questions to please use the Q&A box or the chat box to please ask your questions of Dr. Gohar. It was an excellent presentation. Thank you so much for...
Professor Gohar, I am Professor Bukhari. Thank you very much for an excellent presentation. And inshallah, your suggestion, we will have a workshop on it. Thank you very much.
Thank you so much, sir.
And I'll ask Dr. Tabassum again to please begin to ask the questions as they start to come in.
Thank you so much, Shifa. Before I ask Dr. Gohar to respond to some of the questions that have been posted, there are a couple of more questions that are, addressing Dr. Shabi Zaidi, and his response is needed. So, Dr. Shabi Zaidi, if you are listening, would you please respond to a couple of questions? The first question is how to integrate patient safety and professionalism.
Well, there are special guidelines which are available. In the UK, of course, we're guided by a NICE, NICE, and the GMC, but every country has its own modus operandi, and they have guidelines to tell you how to safeguard patients. This is the whole subject. Like God just said, it's a fantastic idea that we can have a series of workshops on different professionalism, safeguarding patients, a very important subject, particularly vulnerable patients, particularly people who are living alone or living with some mental health issues or physical disabilities or mental disabilities. So professional attitude has to be, you have to give respect to the human being as a human being, as if he's part of your, you see, if you feel that a person who's coming to you, subject or patient, is like a family member, then all the issues can be resolved. It's the dignity and honor that you must give to the person. Dignity and honor are the fundamental, plus the competence that you have in handling with them. How do you handle a patient with this disability? We have patients who come with a lot of attitude problems in clinical practice in the NHS. I know Susie is also somewhere. She's a very experienced clinician. She can also chip in. So how do you manage those angry patients? Now, what we have in the UK is that we run these courses, the GMC and the different organizations run short courses, special courses, which you must do every year, X number of courses, like how to handle an angry patient, how to handle a patient with disability, even weightlifting and moving and shifting, etc. Likewise, I would encourage that every country, any person who's living from different countries, they should develop their own formats of designing these parameters and developing the guidelines for different aspects. Before I finish, Gohar, I think we should do this workshop on professionalism with your friend. Evaluation is one thing which is absolutely ignored. So we can do a workshop, we can, if I can announce it for January or February, maybe. Thank you. Any other question, Tabassum?
Yes, Dr. Shabi, there's one more question related to the role models. The question states that role models are hard to find these days. So your viewpoint and your comment on this.
I think it's very difficult. That is true, absolutely, because the whole society has changed. We've gone from a very organized society to a destructured, dysfunctional society. But still, within your family, within your colleagues, within your seniors, even peers, you can find, you have to look at certain characters. What can I learn from a person? So if you identify a clan or a group or a family member or teachers, there are wonderful teachers everywhere, right across the world. I remember when I was doing my FRCS, My favorite teacher was Professor David Sloan. He was a professor of physiology at the Royal College, very old person. He was already about 75 or something in 1968. He was my role model. He lived a simple life. He came on a bus or a train from Kent somewhere to London, teach all day, carry just a small jar of water, simple living. Sometimes he'll stand with us in the queue. And he used to be my role model and superb physiologist, one of the best teachers I've had. And still today, when I teach, I think of him, how would he teach? So we can develop a role, we can find role models if you look for them, surely. Thank you.
Okay, Dr. Gahor Wajid, now the questions are directed towards you. The first question is whether there is an ultimate limit of professionalism in medical practice.
Well, the brief answer is sky is the limit.
Yeah, of course. So obviously,
let me elaborate. When I say sky is the limit, it means practically there is no limit, but it does not mean that we need to keep professionalism unlimited. What it means is that we need to define the boundaries of professionalism by ourselves. That's why I said that the role of regulatory bodies in defining the definition of professionalism from getting away from that constitutional definition to entering into the operational definition, then defining its boundaries of what is expected of a doctor or a health professional is very important. But once we define those boundaries on what is included in professionalism and how much it is including, then this forms a basis of what we call ethics. But then on top of ethics, there is something we call morality, and there is no limit to morality. One can be as much moral as one's own limitations. So that's why we say that professionalism has basically no boundaries, but it does not mean that we have to keep it stray and a vague topic. These boundaries have to be very structurally defined in any outcome-oriented competency-based curriculum and practice.
Can I just expand your discussion on this definition of morality and ethics? You're absolutely right. Ethics is inferior to morality. You're absolutely not a lot of people would say that. It's a very subtle difference. Very well put it. Morality is more like philosophical principles. It's moral high ground. It's like theory. But when you apply it into practical forms, then it's ethics. And when you apply in medicine, then it's bioethics. So there's different categories. And yeah. God willing, we'll do a workshop on that some stage. Thank you.
Okay, so we have been talking a lot about, doctors and medical students, but there's a question related to nurses, and it says that how to teach professionalism to nurses.
This is how you might have noticed that most of the time I did not use the term doctors, rather I use the term health professionals. Now the dynamics of teaching might be different at their levels, but the principles of teaching remain the same. So we have to think of, like Professor Zedi said, teaching through role modeling or teaching of what exactly goes in teaching that is knowledge based, then psychomotor skill based, and then behavior based, or getting into what kind of competency based teaching it could be. For example, the competencies at the level of nurses that are expected from them might be different than the competencies that are expected from doctors. So if the competencies are different or the levels of competencies are different, then we'll have to develop those alignment mechanisms of what exactly goes in the nursing curriculum, how it is going to be taught, and how they are going to be assessed in terms of professionalism. That would be very well defined for a professional nurse, which could be quite different than a professional doctor.
Right. So once we are talking about teaching professionalism, and now comes the assessment of professionalism. So the question is that assessing professionalism can be used through portfolios, right? So, but portfolios can be subjective to assess. So your viewpoint on that?
See, the use of portfolios over the years has increased as tools for mainly for formative assessment, but they can still be used even for summative assessment as well. So in any institution, how much weightage you are going to give to portfolios, what exactly goes in portfolio, how students are going to approach portfolio development. And that's why that reflective practice-based model, which I showed, it forms the basis of portfolios development. If the students are not aware of how to reflect on to their own actions, then portfolio development is a kind of a futile exercise. So I guess that we need to teach our teachers, first of all, and we need to develop a very systematic kind of mechanisms through which portfolios can be introduced. Then we need to define the clear role of portfolios, whether it is the kind of self-portfolio that is my own portfolio, or that is going, it's an academic portfolio that is formal requirement from an institution. If it is academic portfolio, what is expected of an institution, what exactly goes in the portfolio, and then the role of portfolio in both formative assessment and summative assessment. And not to forget that this is where teaching feedback to the teachers is very important, because if the student does not know how to reflect, and if the teacher does not know how to give proper feedback, then portfolio exercise remains a futile exercise. Thank you. Over.
Okay, thank you so much. There's another question related to justice, and it talks about, is it to be decided within medical professional, or some other people can also be given a chance to decide what is justice?
Professor Zadi. Sir, who decides what is justice in terms of medical profession?
Justice is a vast subject. So very briefly, I say there are two forms of justice in medical profession that we encounter, and I think universally: distributive justice and retributive justice. These are two fundamental. Now, justice doesn't have to be basically the same. It's in fact not has to be. It's not the same as equity. Equity is different to justice. Justice means to be able to give a person his due, or to put a thing or an item in the right place where it belongs. Anything that's against it will be the opposite of justice. Okay. Now, how do you define justice? It's a very difficult thing. I think right from the days of Aristotle, it has been a debate. It's been going on forever. But the simplest definition is to put a thing in the right place where it belongs, and to give the thing to a person to whom it belongs is justice. Now, in medical profession, a very important subject that's currently in debate is distributive justice. For example, during the COVID era, we found that the resources were limited, and we had some degree of compromise of distributive justice. Like PPEs, for example, were not given in the initial stage. Like I'm talking about UK and other countries, a different matter altogether. So services within limited resources is an important aspect of distributive justice. Retributive justice is that if you punish somebody, that punishment should be compatible with the crime is committed, not excessively. If somebody, for example, is a small thief, well, you kill him for that. That's not justice. Means retributive means should be compatible to the crime committed. Distributive means it should be distributed according at the level of say distribution of services, for example, at level playing fields. The best theory is a theory of social justice by John Rawls, on which the NHS, for example, works, that you provide a service based on justice at the first point of contact, not a point of contact depending on the need, not the greed, not the affordability, not the amount that you can pay. In different countries, justice, some people, nobody says it's not just. I mean, even Saddam would not say that he was not just. To his people, he would say that his own clan would say. Justice is a very abstract thing. Justice is something that's sitting in your system, in your conscience. And since you cannot see conscience, justice cannot be seen until the time when it's executed. So you have to show it, prove it through a certain action. Thank you.
Okay, so there are many questions that are coming in. How do you see some practices of surgeons to play music or tilawat in the operation room in light of professionalism?
So should it be there or it should not be there? These are the cultural dimensions and aspects of professionalism. And any society, they could vary, by the way, tremendously from one society to another. That's why when we define professionalism, and when we define the professional boundaries of professionalism in a particular society, these are the nitty-gritty elements at micro level that we have to take care of. That's why the boundaries of professionalism might vary from one culture to another. In one society, they might prefer having tilawat. In another society, they might prefer having music, and so on and so forth.
You're absolutely right, Gauhar. You said a very important topic that you briefly, in fact, you should elaborate it later on one day. Contextual. It is contextual and it is cultural. There is a very important debate in the circles of philosophy, and Ali Tariq is also listening. He's a good student of philosophy in Iraq. He'll correct me if I'm wrong, that when we talk of these delicate subjects of culture sensitivity, we have to remember there is a thing called moral relativism. That should be condemned. A lot of philosophers think morality is relative. No, it is not relative. Morality and ethics are universal. Truth shall always remain truth. Justice will always remain justice. Loyalty will also, but people circumvent it by using it to their advantage. That is called moral relativism. That should be condemned. In my view, I'm dead against it. Thank you.
Right. So there are questions related to, a social and cultural perspective as well. Can professionalism be shaped by cultural and social perspectives?
Go ahead, Gosen.
Yes, there are so many attributes. Yeah, there are so many attributes that are shared attributes. Professor Zedi mentioned some fundamental pillars of professionalism. So when you are developing a particular model of professionalism, what goes in a particular curriculum for a particular profession, then the regulatory body or the society that is forming that model, there would be stakeholders from the society. This is exactly what they need to look into. What exactly goes in professionalism? What are the fundamental pillars around justice and how they are defined, and how empathy is defined and incorporated in the model, how communication skills are defined, how breaking bad news would be working. That's exactly what the definition, the operational definition, again, I'm saying, of professionalism would entail on certain fundamental principles being elaborated in the form of, that's where Usman's model of the analogy of apple tree. Now there can be many apples, but these apples have to be defined by the by some institution. For example, in case of Pakistan, it could be Pakistan Medical Dental Council, in collaboration with other stakeholders, for example, the patient rights bodies, the government, the society, Society of Physicians and Surgeons, Pakistan, etc. That's where they define exactly what goes in the relative definition of professionalism that is applicable to a particular society.
Could I just add that there is in the context of contextual variation of professionalism, it's a wonderful example. This was an article that was written by a famous person some years ago, that the values play a very important role in professionalism. And there is a difference between the culture of the East and the West. We have lived in both areas and we know the difference. Every culture has its own important values, which must be respected, and respect them all. But there is a cultural variation, for example, and that's embedded in your society, in your system. And that also might answer the question, how do you transfer that experience of or that practice of professionalism? In the West, when you see a professor or a colleague, because when you first came from different countries, we would get up and treat that person like our father. Later on, we realized that they did not want it. They said, call him by first name. So in the West, for example, to be intimate by calling even your senior most professor by first name is expected and is respected, is acceptable. But you cannot do the same in the East. In the East, he'll take an offense. Oh, I'm such a big professor and you call him a first name. You can't do that. Likewise, in the Eastern culture, when somebody elder walks into the room, you get up, greet him, right? You say welcome, whatever. In the Western culture, it is not. It is not. Everybody is autonomous. So likewise, these respects, these values, for example, I'll say in Urdu because I have to say it, it's embedded in your language, in communication. Tu is somebody junior, somebody not respected like that. Tum is about your level. Aap is somebody senior, more senior. Janab is even more senior. Qibla, more senior. Huzur, ultimate. So they're embedded in your language, in your culture, in your transmission and display. These will all apply to professionalism, whether it is alim ad-din or a medical doctor. That is embedded in the system. So anthropologically speaking, culture plays a very important role in morality, ethics, and professionalism. Thank you.
Yes. So there's one more question which is related to social behavior and says that can professionalism be improved by improving social behavior of doctors with your patients or clients?
Sir, maybe you can go ahead.
Go ahead. Well, of course it can. I think it's a very simple thing. It's a very simple thing. I think it's a question of being sensitive to these values. If you cannot practice what you preach, then you're not being a professional, fundamental things. So obviously you practice those things like respect and dignity and honor and truth and justice and all those factors. If you apply to them, use them in your practice, then obviously they'll be transmitted to the process of osmosis, your junior, your colleague, whoever is your student, and we're all students to each other in our lives. We learn from each other. So it can be, yes, you can improve it by playing the role of a role model, by applying them to yourself. I mean, we're all sinners, we're all bad people. I mean, that is why we ask for forgiveness from God, not for justice, not for other. Never ask Allah for other. You ask for forgiveness. Rahm.
Thank you. And there's one last question, which is directed towards Dr. Gohar Wajid. It says that working in WHO, what are the most important values that are globally applicable in medical professionalism?
I believe that WHO promotes all the fundamental pillars that were mentioned by Professor Zedi, right? Starting from autonomy of the profession is very important, the dignity of patient and different other elements of the society. Confidentiality is very important. Then like fairness and justice to the treatment, and then in terms of access and accessibility of different patient groups to different treatment modalities, all these what Professor Zedi in his presentation mentioned as fundamental pillars of professionalism, they are very important and very well advocated by WHO to be incorporated in all curricula and professional practice.
Right. Thank you so much. There is one question, I guess, which is addressing towards Dr. Shabir Zedi, and this is the last for him. If professionalism is to be taught in hidden curriculum, can it be taught like medicine? Then how we can assess it like normal assessment tool?
I think that question should be addressed to Dr. Gohar Wajid, because his presentation showed exactly those things. An assessment is a very difficult thing. Gohar, would you like to come in?
Yeah.
Thank you.
You see, we cannot leave such an important issue like professionalism exclusively on hidden curriculum. First, we need to understand that professionalism is something important. That's why I showed one slide of unprofessional behavior that distincts between what is professionalism, and if professionalism is not there, what we are left with is unprofessional behavior of doctors or other health professionals. Now, once we agree that professionalism has to be there, then we get into the discussion around the fundamental attributes and those qualities that we want to see up in a particular professional. That's where multi-stakeholder activity and multiple groups would be involved, who would be involved in developing that formal curriculum around which we are going to frame the teaching and assessment of professionalism. Once the attributes and the models are defined, that will help us to identify on how we are going to teach professionalism. Then how we are going to teach, what is the knowledge domain of it, what is psychomotor domain, and what behavioral changes we expect in a doctor once he enters in year 1 and once he exits in year 5. So I believe that we must have formed his professional identity by that time. That's where the whole thesis of my colleague Dr. Ahsan Sethi was there, how professional identities are formed among health professionals. So once that is done, then remains the issue on how do we ensure that the professional attributes that we defined, they have been achieved by the doctors. So that is where all those semantics and dynamics of psychomotor assessment play their role on what exactly goes to be assessed through formative assessment, what goes in summative assessment, what is to be assessed through OSCE or workplace-based assessment, or through 360-degree evaluation or portfolios, or even through multiple choice questions, etc. So it has to be structured pretty well. It cannot simply be left to hidden curriculum alone.
Thank you, Dr. Gaur Wajid and Dr. Shabir Zaidi. These were the questions that were addressed and directed towards both the presenters. Now over to you, Shifa, please.
Thank you so much. I'd just like to invite two special guests. And first off, Dr. Shabir Zaidi has asked Dr. Fatma Ali to please speak about her experiences on professionalism in distant healthcare. Welcome, Dr. Fatma.
Thank you very much, Shifa. Assalamu alaikum, Professor Zaidi and Professor Wajid. It's really honored to be here, and thank you so much for inviting me yesterday into this brilliant meeting. I really enjoyed listening to both professors thoroughly. Whatever they have said, obviously we have practiced for the last 20 years in the Western world. Many things have been changed, particularly Professor Wajid was saying about reflections. Do you know, there is a time right now, we are so overburdened with writing reflections. I know the organization is trying to assess us and, you know, whether we are professional enough. We are quite mature, and they are asking us reflections. Some of us are saying, hey, this is all common sense. You cannot teach empathy by pushing doctor to write tons and tons of things, because we have given like some 80 to 100 domains to reflect. So you can imagine how much it's going to take our time. Anyway, coming to the topic, thank you. And professionalism in my part of work. So what I'm doing, apart from being an anesthetist, I have started working in developing part of the world in Pakistan, the extreme north, Gilgit-Baltistan. And this was an accident that I have started working in education. This was March 2019 when I visited a village. I was asked to see some patients there. When I noticed that in one house there were 4 disabled children, the next house there was another disabled man. When I saw in the village, first ever time visiting a village, that there are these children all over the place, and they're shacks and mud houses. So it's kind of shocked me, and I said, where is the school? Where is the playground? How many people? So in small houses, there are 10, 12 children. So it shocked me, and I got kind of, from the very time, I just done one thing. The cause of these illnesses and the cause of problem is lack of education. If we educate these children, at the highest level, at least a quality education, if they give these, I personally believe we can change the life, because there were so many illnesses, they were just down to bad hygiene, lack of awareness. And then they were all trapped in a cycle of poverty. So that was the reason I started working in education. When I established the first Montessori style school education in the first village, it went on the social media, it became popular. So today, in more than a year, we have, alhamdulillah, established 23 Montessori style schools in extreme wide part of Gilgit-Baltistan. Gilgit-Baltistan is quite big. It's 72,000 kilometer square area. And it's really, you have to take, from one part to other. And it's so difficult. The road and sometimes there's a single high-risk jeepable road. But alhamdulillah, I've managed to go to each and every area to assess. So my assessment has left me traumatized. So whatever we are talking, so we are elite people here, we are very privileged people. So my way of justice in professionalism would be when I have seen some place like that, and I should share my expertise. As a doctors, we must not sit in our comfort zone. I believe where we are living is perfectly comfort zone. Even in the cities, even the city like Gilgit is perfect, beautiful and comfortable. But I would request to move outside the urban areas of developing world, and you will see the premise. A hell is open there for you to work really. So whether I talk about education there, whether I talk about the health services, forget about health services. Most of these villages I work, there's no health service at all. So, some places there is definitely no network. Some places there's not a road. So believe it or not, I first ever rode a donkey to reach a village recently. So, so I don't know what to talk about professionalism. Apart from, if I talk about coming to urban areas, so what we practice in Western world, unfortunately, whether it's private or whether it's public, the professionalism not practiced. I'm sorry, you might find me critical. There are lots and lots of improvement is happening, but I'm still not happy the way improvement is going on. And the reason for that is there's corruption in each and every fabric of that society. And we cannot change the developing world until unless we, the doctors who have learned the best of the best techniques or professionalism from the West, we take it to that part of the world. I don't believe someone is going to come, or the government will change, or the religious clergy will change. So I have to tell you one thing about the religious clergy. Out of all that chaos and mayhem in the villages, when I say villages, there are thousands and thousands of villages. There was one thing which was big and very prominent, a mosque or a Husseinia or some form of religious area. So I was like shocked. I said, how come? Because in the Western world, all doctors trust the religious clergy to go and fix the problem there. And I think it's not working. So I would request all the doctors, all my colleagues around the world, that the developing world does need our expertise and professionalism rather than we giving our job to someone else. It's very easy to pass on a few pounds or shillings or some money, but it's very difficult to go there practically and do some work. And it is needed all over the developing world, not only in Pakistan. So I don't know, this is my take on professionalism. Justice cannot be served. We cannot do as doctors justice. We have seen the world. We need to share our expertise into the developing world. Thank you so much for this time.
Thank you so much. And next, I would like to invite Dr. Fahim Nanjiani, who will be speaking on distance learning and his experiences in distance learning. Welcome.
Thank you, Dr. Shifa. A'udhu billahi minash shaitanir rajim. Bismillahir rahmanir rahim. Salamun alaikum wa rahmatullahi wa barakatuh. I'll try to be as brief as possible. Distance learning was phase 2 of the whole project. This project was thought of in 2017, and we started with telemedicine. I'll share with you a brief video, which will give you an idea as to what this project was. So here we go.
Telemedicine online. The objective of this is to provide the best medical practice 24/7, to educate junior doctors and to educate patients and communities. What we offer is to try to diagnose the disease or problem rather than treat the symptoms only. We can also minimize the list of medicines needed to treat a specific problem. The provider of the service is GPs and specialists in the UK, North America, and Australia. This platform will be available on any site in Pakistan and India. The services can...
Right, so initially it was introduced in Pakistan, and we had 3 sites, one in Karachi, which was a school, the other one in Lahore, which was a religious madrasa, and a community in Gilgit-Baltistan, where Dr. Fatima Ali is doing her good work. We saw about 200 patients in a space of a year and a half. It was easy for us, but difficult for the arranging organizations there to arrange. As you know, there is no job plan and they couldn't find a person to run the clinic. The idea was to introduce telemedicine and then to educate the doctors who would act as a facilitator at the other end. In that regard, we couldn't do it in the model that was initially thought of, but what happened in the beginning of this year, I'll read an extract from my appraisal this year because it will save a lot of time for all of us. So around the beginning of this year, I was approached by a medical student from my parent country, which is of course Pakistan. She is a coordinator of IMI. I believe many of you might know her, Dr. Samra Mehdi Kazmi. She requested me to arrange a course for final year medical students and house officer, which is an equivalent of FY1 in UK. And then came the pandemic and most of the medical universities were shut in Pakistan. I then advised her to arrange regular online teaching sessions for groups of students and doctors. After conducting a national online presentation on approach to emergency department patients, in which 60 students and doctors participated, I started holding interactive problem-based learning session online for groups of 4 to 6 doctors. Altogether, there are now 17 doctors. Over the last 6 months, Alhamdulillah, we've held 40 plus sessions of 90 minutes duration each on topics including chest pain, dyspnea, abdominal pain, upper GI bleeding, ENT and eye emergencies. Now, the final thing, so 2 more minutes. The format of these sessions is such that one candidate is supposed to be a doctor and another one is a critic. I present myself as a patient and then the doctor asks me questions that they would ask a patient. Following this, they would do a virtual examination and I would give answers to what were the findings. This would be followed by investigations, some of which, such as ECG and X-rays, I would show them online. And others, like blood results, would be given by myself. They would then come up with a differential diagnosis. After discussing further tests to confirm the diagnosis, they would be asked about management of that condition. These exercises were very much appreciated and we are still running it. So that's the phase 2 of the whole project. Phase 1 being telemedicine, phase 2. I believe the phase 3 should be giving scholarship to the doctors in Pakistan, and phase 4 doing an audit. Thank you very much.
Thank you so much, Dr. Nanjiani, for your expertise and for Dr. Fatma as well for sharing. That concludes our webinar for today. Thank you to our speakers, to Dr. Gohar Wajid and Dr. Shabi Zaidi, to Dr. Tabassum Zahra for moderating our Q&A. I'd just like to tell all of our attendees to please remember to register for our upcoming workshop on mentoring in pandemics in the COVID-19 era by Dr. Farzana Mehdi of ARIS of ARIS University in India, and that will be on December 5th, so 2 weeks from now. So thank you again, everyone, for participating, and we hope to see you again soon.
Thank you, Shifa.
Thank you so much.
Thank you.
Thank you, Gaur.
Bye-bye.
Thank you. Thank you, everyone.
You will take up your project in January onwards. Inshallah, we'll expand your services and request you to share your experience with IMI and SIVU globally, not just Pakistan, all over the world. Thank you.
Thank you.
Thank you and goodbye.